Today the LAPACT trial presented again. It was previously presented at ASCO at ESMO. This is a multicentric international phase 2 trial looking for the role of nab-paclitaxel gemcitabine in locally advanced pancreatic cancer. So 107 patients were enrolled in this trial. 106 received the treatments. The patients received 6 cycles, were enrolled to receive 6 cycles of nab-paclitaxel gemcitabine, and after 6 cycles, it was for the investigator to decide whether to continue the chemo or to modify the treatment for a chemo-rad or to operate on the patient for those who are deemed resectable. The primary objective of the trial was the median time to failure, and the secondary objectives were the median progression-free survival, the median overall survival, the quality of life, and the objective response rate. So the median cycles of treatment were 5, which is a good treatment, a number of cycles. This is what we've seen in the metastatic impact trial. The primary objective, the median time to treatment failure was 8.8 months, and the median progression-free survival was 10 months. The 1-year overall survival was 72%. The objective response rate is 35%, and we remember that in the impact trial, the metastatic trial, the objective response rate was 23%, and for the FOLFIRINOX trial in the metastatic setting, the objective response rate was 31%. This is a phase 2 trial, so usually we see the results better than the phase 3 trials, and especially in locally advanced, with the prognosis a little bit better than the metastatic disease. The median PFS is what we were expecting, and it's similar to what we see in our daily practice in this type of population. The 30% of patients initially are not considered resectable. Usually in my practice I would say maybe 10 to 15% of patients were considered resectable after a primary tumor, whether chemotherapy or chemo-rad. The problem that in our daily practice, sometimes we are confusing between the borderline and the true locally advanced. This trial is very important because they choose a different population, those who are truly locally advanced and not borderline. This is a good proportion if we can convert 15% of these patients to resection. We had a good experience in the metastatic setting, and the side effects we saw in the LAPACT trial are compared to what we've seen in the IMPACT and outside clinical trials practice. Neutropenia was the most side effect, anemia, neuropathy in just 4% of patients, fatigue in 10%, although in the metastatic setting and especially in the Canadian subgroup analysis, we saw that fatigue was grade 3 fatigue was 17%. And these side effects are, yes, manageable. Because of the weekly schedule, we try to decrease the dose or delay the dose. Sometimes we see if, despite these modifications, we cannot get these patients into a regular treatment, so we use the GCSF. For the fatigue, usually we proceed to delay or modification of the dose. This is very important because we can say that these patients are maintaining their quality of life, and after 5 or 6 cycles, they would be able to get other options like chemo-rad or surgery if deemed resectable. Already many of the provinces had approved this combination for the locally advanced pancreatic cancer, and we do know that multi-agent therapy in locally advanced pancreatic cancer showed a high response rate and may convert some considered non-resectable disease to resectable disease. This gives us an evidence that this option is acceptable and could be used for this type of population. The message is we have to consider the multi-agent treatment. Nab-paclitaxel gemcitabine is an option, and we have to discuss after at least 5 to 6 cycles in a multidisciplinary team, whether to continue the treatment or to modify for a chemorad and get more response. It's going to reinforce the current practice, and it will give us an evidence that nab-paclitaxel gemcitabine, beside other regimen, is an option for this indication.